Thanks a lot for the melodious and auspicious start to the event. Friends, today's first session is on chronic myeloid leukemia. Am I audible? Yeah. CML, though it is termed leukemia, cure is possible without chemotherapy. To more about this, we have with us Dr. M.B. Agarwal. And let me introduce Dr. M.B. Agarwal from Mumbai. He is professor and head of the Department of Hematology, Bombay Hospital, Institute of Medical Sciences. Consultant hematologist at Lilavati Hospital, Breach Candy Hospital. Is a president of Mumbai Hematology Group, past president, Indian Society of Hematology and Transplant. I'm very sure everybody knows Dr. M.B. Agarwal. Above all this, he's a great teacher and nobody wants to miss an opportunity to listen to him. Agarwal sir has to leave the session immediately after the session. So I request all the participants to kindly write their questions in the question box. I request the same for the other speakers as well. Sir, we are all ears to listen to your words of wisdom. Over to you, sir, Dr. M.B. Agarwal.
Thank you. Can you see my screen?
Yes, sir. Yes, it is visible.
Yes, thank you so much. So I'm going to speak about high WBC. CML is curable now. First of all, I must thank the architect of this webinar, Dr. Seema Bhatawdekar. Greetings from Mumbai Hematology Group. It takes a big heart to shape little minds. And Dr. Seema has been a teacher to all of us for last 14 years by holding these yearly CMAs in hematology. Hematology is quite colorful, like this tree. And you'll agree how beautiful these cells look. The big news of the day comes from ASH 2020. ASH is American Society of Hematology, and the meeting was conducted just less than a month ago. And the news is that chronic myeloid leukemia has been conquered. It's a time to celebrate. Some time ago, I had shown this picture in one of the SEMA's meeting, and I had said that the stethoscope is dead. With X-rays and CT scans and echoes and ECGs, you just keep the stethoscope with you to be recognized that you are a doctor and not a ward boy. Same thing today, as was introduced by Dr. Bhide, CML has been conquered with pills which do not contain chemotherapy. Virtually, chronic myeloid leukemia is dead. Let me begin with the differences in the Western world and India. What is the age at which chronic myeloid leukemia occurs? And if you read your books, they'll mention that the median age is 64. As usual, the books are written from US and Europe, and that's the median age. That means half of the patients in Europe and US are above the age of 64, and that means it's a disease of elderly. Let me give you another perspective. In all the published series from India, whether it is from PGI Chandigarh, whether it is AIMS Delhi, whether CMC Vellore, any part, east, west, south, north, the median age of CML in India is 42. And what does that mean? It means half of the patients of CML in India are younger than 42. In other words, these are people who are free from comorbidities. That's the age where you do not have hypertension, you do not have diabetes, you don't have ischemic heart disease. You're a healthy, normal person, and you get this disease. This has a tremendous bearing on the treatment, as we will soon see. How do you diagnose chronic myeloid leukemia? And I'm going to tell you two cases. My first case, which is an eye-opener. Anubhav, 27-year-old, male from Vadodara, undergoes pre-employment blood checkup. His hemoglobin is 14.5. His total leukocyte count is 11,900 and the platelet count is 4,80,000. He has no symptoms, he has no signs. He saw the normal range and found that his white cell was 900 more than the cutoff for the upper limit of TLC, and his platelet count was 30,000 more than the upper limit of platelet, which is given in the column there. He spoke to his family physician. Family physician just brushed it aside. He said, nothing to worry. Anubhav was not convinced. He sought the opinion. He was asymptomatic. There was no fever and there were no findings on the examination. So what's the interpretation of Anubhav's blood counts? Well, you don't really have to be a Sherlock Holmes to diagnose this condition. We looked at his previous health checkup records, and that showed, and he had at least about 5 blood counts done in the preceding 5 years. His total leukocyte count was never more than 7,200. And his platelet count was never more than 262,000. That is 2,62,000. Though we say that the normal WBC count is 4,000 to 11,000, the normal platelet count is 150,000 to 450,000, for a given individual, the counts are very often in a very narrow range. If for 5 years your white cells are 7,000, your platelets are about 260, then that's your normal. And that means his present count was way above his normal. And of course, it was above the normal range given for anybody. When a person without fever has high count, that's highly suspicious of malignancy. In infections, you are sick. In malignancy, you are healthy. The first thing that comes in the mind is chronic myeloid leukemia, and the diagnostic test is a molecular test, the BCR-ABL. The test was ordered and it was 89.2% normal, obviously being non-detectable. For everybody's comfort, the test was repeated and it was same. The diagnosis of chronic myeloid leukemia, chronic phase, was established. And his prognostic score was, what is called Sokal score, was low. Keep this in. Let me show you my case number 2. Narsi Bhai Patel, 80-year-old from Surat, with lot of comorbidities, diabetes, hypertension, ischemic heart disease, chronic obstructive pulmonary disease, operated for CA prostate in past and now having a normal PSA. He was not feeling well for almost a year. And now he felt terribly exhausted, lost 12 kg of weight and felt that his left upper tummy is bulging. Family didn't go beyond the family physician. However, a companion brought him because he felt that there is something amiss. Examination showed that the spleen is 7 centimeters below the costal margin. His hemoglobin was way down, 8.3. His white cells were way above 536,000, that is 5,36,000. The platelet count was 12 lakhs. BCR-ABL 1 was 96%. He was also chronic myeloid leukemia, chronic phase, but this time with a prognostic Sokal score, which was very high. So friends, what you saw was 2 extremes of chronic myeloid leukemia. One, where the counts were subtle, but enough to order for the BCR-ABL, and the second, which was a gross, absolutely neglected case of CML for quite some while. In this case, to be precise, 1 year. The standard case is like this, around 42 with bulge in the tummy. When you look at the differential WBC count, it is very, very diagnostic of chronic myeloid leukemia. And you just look at the figures which are in red on the right side. The peripheral blood film will show you that there are hardly any myeloblasts. So this is not acute leukemia. There's a big peak of myelocytes, 21%. And there are peaks of eosinophils and basophils. Now you can imagine that somebody has got a count of 500,000. 3% eosinophil, 5% basophil means quite a lot. This is almost diagnostic before you order for the BCR-ABL. Let me take you a little bit to the history of chronic myeloid leukemia, and you can't forget 2 names, Peter Nowell David Hungerford. Sitting in their lab in Philadelphia in 1960, they appreciated this. 2 chromosomes, one becoming little longer, one becoming little shorter, because of the reciprocal translocation between some material between the 2 chromosomes. One was the 9th chromosome with the ABL gene, and one was the 22nd chromosome with the BCR gene. And this reciprocal translocation allowed these 2 genes to fuse together. The BCR-ABL genes fused. This fusion of BCR-ABL was not detected by Novell and Hungerford. This was detected by Jeanette Rollet. Jeanette Rollet just died 7 years ago. After having seen the history and the diagnosis of CML, let us look at the prognosis. Not every CML patient behaves in the same way. Most important is the phase of the disease. We showed you examples of 2 cases, both in chronic phase, so they are relatively better prognosis. But somebody can have accelerated phase and somebody can have blast phase, which has bad prognosis. And then we have prognostic score, and I will show you that very soon. When you do the bone marrow karyotyping, normally PH chromosome will be present in most of them, but some may have extra chromosomal abnormalities, and that's a poor prognosis. When you do BCR-ABL, there are certain transcripts, and that can also tell you good versus poor prognosis. And the most important in any cancer is the response to treatment. When we come to the treatment, we will discuss this word TKI, tyrosine kinase inhibitor. If you respond well to TKI, you do good. If you don't respond well to TKI, you do not do good. So these 5 are the best prognostic factors. Now look at this. In the TKI era, the green is the chronic phase. 6 years, 8 years, over 80% of patients are alive. While if it's an accelerated phase of blast crisis, hardly anybody is alive. I was telling you about the prognostic score. The most commonly used in India is Sokal score. And as most of you are not hematologists, I'll stick to this score because it is based on 4 very simple parameters. Age of the patient, we had a young guy and we had an 80-year-old guy. Spleen size, we had a guy without spleen and with a big spleen. The platelet count, we had a guy with a very little increase in the platelet and massively increased platelet. And peripheral blast cell count, fortunately both didn't have any. So this decides low, intermediate and the high Sokal score, which in turn tells you the prognosis. And now the most interesting part of my talk, the management, for which probably you have assembled today. Treatment of chronic myeloid leukemia has undergone a revolution. Radiotherapy came in the beginning of 1900. Before that, the treatment was remove the spleen by surgery. Because patient's discomfort was spleen and not chronic myeloid leukemia, you remove the spleen, patient's discomfort disappeared. Median survival was 3 years, whether you removed the spleen or you didn't remove the spleen. Radiotherapy came, surgery disappeared, spleen could be reduced by radiation. Patient became comfortable, but his survival remained 3 years. Second World War, nitrogen mustard as the war chemical gas and a derivative busulfan, alkylating agent, made both surgeon and the radiotherapist obsolete. This was the beginning of chemotherapy, oral pill, but chemotherapy, spleen disappeared, counts became normal, median survival remained 3 years. Busulfan was very strong. Some people died of aplastic anemia due to busulfan. So came a little milder chemotherapy, which was equally effective, hydroxyurea. And it is a shame that in India, still chronic myeloid leukemia, some patients are treated with hydroxyurea. Why is it a shame? It's a shame because though hydroxyurea will give you wonderful control of spleen and the counts, median survival will remain 3 years. So Anubhav, who is 27, has a 50% chance of dying at 31 if he's treated with hydroxyurea. While I'm going to tell you the treatment with which he will be cured, and he will live to maybe 80, 90 and 100 years. When I began my practice, a biotherapy came, interferon, in early 80s. It replaced all this because for the first time this biotherapy made the PH chromosome disappear. And the life from 3 years got extended. And I have patients whom I treated with interferon in 1980 and they're alive till today. However, that's an exception. The median survival increased from 3 years to about 6 to 7 years. And then came stem cell transplant. And that was a huge thing because if you were transplant eligible, that means you were relatively young. If you had a donor, if you had the money, and if you are in that part of the world where transplant facilities existed, then half of the patients got cured. But that amounted to 1% of the total CML patients in the world. Because huge number of patients either didn't have an access to transplant or were not fit for transplant or didn't have monetary resources or access to a center. So this was a cure for half of the patients, but that amounted to 1% of the total number of CML patients in the world. Other half suffered. Either the disease came back or they died of the transplant or they developed a new disease, graft versus host disease. So though you subjected your patient to stem cell therapy, but reluctantly. And then a miracle happened. And that miracle was TKI. So this is the timeline of the treatment. From the oldest treatment with arsenic to radiotherapy to busulfan to hydroxyurea to interferon to stem cell transplant came the era of TKI. Imatinib in 2001 and second generation, the modern TKI in 2006. What exactly TKI and what exactly TKI does? So you got the two genes, BCR-ABL and the ABL. I'm sorry, the BCR and the ABL. ABL on 9th chromosome, BCR on the 22nd chromosome. When they fuse together, you have this tyrosine kinase. And what does it do? By taking up a phosphate molecule, the tyrosine is phosphorylated, and that is the genesis of CML. And where does the phosphate comes from? It comes from here. ATP to ADP, and the phosphate comes to tyrosine. That's the job this fusion gene does at the molecular level. Now, you have this molecule imatinib. This is tyrosine kinase inhibitor. It goes and sits in this pocket. So now ATP cannot donate its phosphate molecule to tyrosine. CML cannot be formed. CML dies. And Time magazine published this article with the cover page, the magic bullet, 20 years ago. From chemotherapy to interferon to Gleevec was a huge jump. After 72 months, that is 7 years, you got 80-90% of patients alive. And then see here, after 14 years or after 10 to 14 years, 90% of the patients with TKIs are alive. You conquered CML to some extent. So from a fatal disease, you converted into an indolent disease. From a poor prognosis, you made it an excellent prognosis. From a 10-year survival of 10%, you made it 90%. From the interferon or transplant, you moved to the TKIs. And after failure of transplant, there was no treatment. Now, in case the TKI fails, you still have the treatment in the form of novel TKI or reluctantly even the transplant. How do you follow up a patient of CML whom you have put on imatinib? And once again, it's a shame that many people are followed up by a technique called FISH, which is obsolete as far as follow-up is concerned. Or they are followed up by qualitative RT-PCR for BCR-ABL, which is also obsolete. The best way to follow up is the quantitative, what is called RQ-PCR, where you look at the BCR-ABL from 94% coming down to ultimately 0. And if that does not happen, then you search whether the BCR-ABL kinase domain mutation has undergone some mutation. So at diagnosis, you have BCR-ABL, which is huge like an elephant. And you want to reduce it in 3 months to less than 10%, and by the end of the year to less than 1 year. Your molecular response at 3 months, less than 10%, decides what's the outcome of your patient will be. Look at here. If the BCR-ABL becomes less than 10% at 3 months, then the survival of these patients after 8 years will be 90% plus. But if that does not happen, then the survival will be only half. And you don't want that in 2021. You don't want that. So if your BCR-ABL after 3 months is more than 10%, you need to move on so that you can once again have a success rate of 90% plus. So let's discuss something about this wonderful magic bullet, the TKI, the tyrosine kinase inhibitors. And you've got plenty of them, including in India. Imatinib came as Glivec, dasatinib came as Splicen, nilotinib came as Tasigna, bosutinib came as Bosulif, ponatinib, Iclusig, not yet officially available in India, but yes, available. And knocking your door is a stamp inhibitor called Asciminib. Two of these are from the house of Novartis, nilotinib and Asciminib, and I'm going to spend a lot of time on them because those are my favorite TKIs. So how do you select from this ocean of TKIs a particular TKI? Will you give imatinib, which is the first generation, or will you give nilotinib, which is the second generation? You got to pick very carefully, or else you'll do harm to the patient. Requires a lot of thinking and discussion. It can't be a houseman's job. Patient entered, he writes a TKI. No, sir. It is the job of Dr. Shashi Apte, Dr. Seema, and people who are consultant with a practice of 10 years plus to rightly choose a TKI for a given person. Because you want to give the best option. You don't want to do anything inferior. 50, 60, 70, 80% survival at 10 years are not acceptable. In cancer, we talk about hit hard and hit early. Whatever type of cancer, the early, the better. Hardest, the best. So we'll discuss three kind of factors in choosing the TKIs. The host-related factor are the first one. Host-related factor we talked about, these are comorbidities. We are very fortunate in India that 50% of patients are below the age of 42. They don't have comorbidities. But if you have comorbidities, you've got to be careful. Is your patient a case of ischemic heart disease? Avoid a TKI which can damage the heart. And at the same time, adjust the comorbidities, handle the comorbidities. So a hematologist is not just a hematologist. He has to be an astute physician. He has to know this formula of A, B, C, D, E. A is antiplatelet agents, B is blood pressure, C is cholesterol, cigarette, D is diet and diabetes, and E is exercise. Even before you think of TKI, first look into this and educate the patient to control this. How is the lung of the patient? Because some of the TKI are bad for the lung, like dasatinib. Is there any pulmonary hypertension? If that is there, dasatinib is bad. How is the kidney? If somebody is elderly, is diabetic, is hypertensive, his creatinine may be low. His creatinine may be high rather, his creatinine clearance may be low. If that, then imatinib and bosutinib are bad. After host-related factor, we come to the disease-related factor, and we partially touched that. What is the so-called score? Is it low? Is it intermediate? Is it high? Because you look at the old first generation TKI and look at the results. 23%, 32%, 36%. Getting into the molecular remission of high degree. This is called molecular response 4.5 degree by 5 year, 23, 32, 36. But if you give a second generation like nilotinib, it is 44, 50, 60. So if your prognostic score is bad, then maybe upfront you think of a better drug. Then the TKI related factor. Each TKI is different from the other one. And that is from the basis of side effect profile. If I got a person who is young, and as I said, 50% of Indian patients are under 40, then my drug of choice is nilotinib. If a person is ready to listen to me, then even if he's got diabetes, even if he's got hypertension, even if he's got ischemic heart disease, even if he's smoking, even if he's obese, even if he's got dyslipidemia, still my drug of choice is nilotinib because the patient is going to listen to me. He's going to give up smoking, control his blood pressure, take antiplatelet agents, control his diabetes, and so on. But if my patient is like my patient number 2, 80-year-old, COPD, hypertension, diabetic, already damaged various parts of the body, I will just give him gentle imatinib. He's got a life of 10, 15 years left and I can manage that with imatinib. But a 40-year-old man or a 27-year-old Anubhav, my goal is not to give him drug for the rest of his life. My choice is to cure him, and I'll prefer a better drug like nilotinib. Each patient has to be assessed whether your treatment is successful or the treatment is failing. If your treatment is failing, before you blame the TKI, look at the compliance. Compliance is a problem all over the world, not in India, not in small town and not in big city. It is all over. Compliance is a problem of human being. I've got patients who look at BCR-ABL. BCR-ABL is 0. They sheepishly ask me, can I stop my drug? I say, why? He said, my BCR-ABL is 0. I say, you stop it, you'll get your disease back. And you get your disease back, probably you can get a blast crisis, you'll die. Despite that, despite all the counseling, there are patients who stop the drug, who reduce the drug, who take the drug on the alternate day, who forget to take the drug, are busy with their life back because they're asymptomatic. Compliance is a huge problem. Each time the patient comes to you, you have to keep finding out what happened to the drug. Has he taken it properly, proper doses, daily or not? If you develop TKI resistance and that is the cause of failure, your BCR-ABL became 0 and again going up, or it is not becoming 0, then you have to switch. Then you cannot persist with your TKI. You got to move from imatinib to nilotinib and so on. How do you move? To which agent do you move? You decide by what is called mutation studies. This is a mutation. This bird could not catch the worm. God made this particular beak so that it can catch. This is natural mutation, and we are looking at mutation induced by the TKI. So these are all mutations. One of the terrible mutation is 315 mutation. After we do the mutation, we look at these mutations and we have this chart in front of us. We look at the mutation, which particular drug it is sensitive to. For example, imatinib does not work on this mutation. Nilotinib does not work on this mutation. Dasatinib does not work on this mutation. Similarly, on these mutations, these drugs may work, may not work, but on these mutations, these drugs will always work. So you look at the mutation and choose your drug. Asciminib is the name which you might not have heard. The ASH that I talked about 1 month ago had at least about 30 papers and important talks and lectures on this, because this targets the gatekeeper mutation. Asciminib is the first-in-class STAMP inhibitor which provides durable molecular responses in patients who have that horrible mutation, 315. And if you combine ponatinib, the third generation TKI, with asciminib, which is the STAMP inhibitor, you can come back to BCR-ABL of 0 in almost all patients. So that's the discovery of the year. What else is the latest news? The latest news is that if your patients of CML are not going to die, and they are not going to die because of the TKI, and with competent people like Shashi and Seema, then the number of prevalence of CML patients in the population is going to rise. From 2000 to 2020, patients have become from 5,000, from 50,000 to 200,000. And what will happen in another 30 years? They will become 400,000. This will be a huge number of CMLs to be treated in the world. So you don't want just that to happen, like diabetics accumulated in the population. You want to cure so that the drugs can be stopped. And these are not CML patients who are here. These are cured normal human beings who are there. So the next job is, and the next goal is biological cure, treatment-free remission. That means you bring the BCR-ABL down to 0 and then stop the treatment and the patient remains with BCR-ABL 0. And this is possible even with a drug as poor as imatinib in 40% of patients. These were patients who were on imatinib. They achieved deep molecular response for a substantial period and then the drug was stopped. Few relapsed who could be put back on imatinib and they got their disease control. 40% did not require the treatment again. And if you start with second generation TKI like nilotinib, almost 60% of patients will not require the TKI again. So the guidelines for CML last month of 2020 is goal for every patient is treatment-free remission. Whether you are young or old, but younger the patient, stronger the reason. Assess the risk, the prognostic score, and choose your TKI very carefully. And if the patient is not tolerating or there's an inadequate response, quickly move to the next TKI. I'm going to stop after showing you 4 cases, which will probably stay in your mind, and all that I spoke will register better. My first case is Priya. Priya is 18-year-old. She's a college student in Surat. She was asymptomatic. She had chronic myeloid leukemia, chronic phase. Her prognostic score, which we use nowadays, is UTOS, was low score. She had no comorbidities. Came from a very good family. Father was CA, mother architect, strong family support. Plan was to go abroad after about 3 to 4 years for further education. And this patient is brought to you. Low risk, no comorbidities, very young. How will you treat this patient? So you got a young girl, desires to go abroad after 3 to 4 years. The goal is to quickly achieve the treatment-free remission. And to achieve a quick TFR, you have to have a quick deep molecular response. And as you know that there are 4 TKIs available to you for upfront use. So Priya chose nilotinib because it is powerful, and at her age, it is free from all the toxicities. 300 milligram BD is the standard dose. After 3 months, the BCR-ABL became 1%. Fantastic. It is less than 10%. After 6 months, 0.02%. After 1 year, non-detectable. You achieved deep molecular response. She had no side effects. We continued the drug for 2 years of deep molecular response and then stopped it. Once you stop it, you should do monthly BCR-ABL, and then you should do 2 monthly BCR-ABL. All that was done. She remained in full control of the treatment. Just before the lockdown in early March, she reached New Zealand. Now she is still in New Zealand. She's started her higher education and she's well placed in a reputed institution. A young girl, cured and back to what she wanted. That was my first patient. My second patient is this lady. 63 female, retired army officer. First seen in 2016. She would smoke, she would take alcohol. She had interstitial lung disease for which she was on steroid and azathioprine. She had kidney stone, recurrent urinary tract infection, needing treatment off and on. So she had significant comorbidities and habits. She was found to have CML with a massive spleen. Her so-called risk score was high. She didn't have hypertension, she didn't have diabetes, she didn't have ischemic heart disease, but her kidney was unhealthy. She had a bad fibroscan of liver showing fibrosis, probably related to her alcohol. So what is her treatment option now? We discussed imatinib, dasatinib, nilotinib with her. We explained her that she has 40 to 60% chance of achieving TFR. Dasatinib was considered unsuitable because lung was bad. Imatinib was not considered good, one because she had a bad type of CML, and this is a mild drug, and also her kidney was unhealthy, and imatinib is kidney toxic. Bosutinib was not available in India at that time. And even if it was available, her liver was not good to choose bosutinib. We put her on hydroxyurea and allow her to think. She thought over 10 days and then opted for nilotinib. And I think rightly so. She made the best choice. After 3 months, her BCR-ABL was 0.9%. First goal was achieved. After 1 year, it was 0.021. And the second goal was achieved. She did have some mild changes which happened with nilotinib in amylase, lipase, liver, sugar, but nothing was significant to stop or reduce the dose of nilotinib, which went on in full dose uninterrupted. After 15 months, it became undetectable and has remained so till March 2019, when she decided, I will go for TFR. 3 years after the diagnosis, 2 years after DMR, the rules were fulfilled and she has gone on TFR. Nilotinib was stopped in April last year. BCR-ABL was monitored every month and then every 2 months till today, and it has not come back. After stopping TKI, sometimes you get a skeletal-muscular pain, which she got, which was managed with NSAIDs. Now she's only on her ILD drug. She gave up smoking and she gave up alcohol because this disease had put a slap on her face. This was my second case. Elderly patient, comorbidity, selected best TKI, achieved biological cure. My last two cases are quick cases. This is my third patient. As you must have guessed from his dress, he's from Rajasthan. So 36-year-old man from Jodhpur, low SOCAL score, CML, CP with no comorbidities. He chose imatinib, and the standard dose 400 milligram we started with. He could not tolerate it. There was vomiting, there was abdominal discomfort and diarrhea. So we stopped the drug, restarted with little less dose, 300 milligram. Same problem, vomiting, discomfort, diarrhea. So this was imatinib intolerance. He said he will not take this and he will rather die. He was switched to nilotinib, 300 milligram BD, tolerated it very well, and doing fine. So this is my third patient. The intolerance to a TKI is manageable. And I come to my last case. And this is my last case. 32-year-old man, self-employed, saw us in 2017. Chronic phase, low score, no morbidities. Given imatinib. At diagnosis, BCR-ABL was 83%. At 3 months, what happened? He didn't achieve a figure of less than 10%. So imatinib was failing. We increased the dose of imatinib to 600 and then 800. And at 6 months also, we did not achieve the goal. BCR-ABL was 31%. So imatinib had failed. We looked at the mutation studies. No mutation was detected. So he had option that he can go for any drug. He chose nilotinib. The dose of nilotinib in this setting is 400 milligram BD. He had excellent response. He achieved deep molecular remission by 18 months. And his plan is that finally he will go for TFR. So that was my fourth patient. First patient was a young girl. She chose a second generation TKI upfront, achieved her goal, went to New Zealand. The second one, my patient, an army officer retired with a lot of comorbidities and therefore chose a second generation upfront and achieved TFR. My third patient was imatinib intolerance and my fourth patient was imatinib failure. However, success was achieved. So the good news is that TKIs are game changers. You are no more on a slippery floor. You are talking of cure. In 40 to 60% of CML patients, upfront, the day one when you see them, you're not counseling them that you will have to take the drug lifelong because more than half the patients will be off the treatment and they will live a normal family life. They can marry, they can have children. If they're married, they can go for family and they have children, they can enjoy holidays with them. So that's my conclusion. Simple oral pill without chemotherapy, CML is conquered. One more leukemia has been put in the back seat. When I was a kid in hematology, acute lymphoblastic leukemia was cured in 50%. Today, childhood acute lymphoblastic leukemia is cured in 95%. This is another leukemia cured, not controlled. It's important to keep updated. Self-reading is difficult. When Seema arranges webinar and you attend, you learn a lot. Thank you very much. That's all the folks. Thank you so much for giving me this opportunity to listen to.
Yes. Thank you very much, sir, for a masterly presentation as always and enlightening us on the subject like a true teacher always does and giving us a clear message that we should keep our antenna high, detect the cases early, diagnose them, but don't indulge into selecting which TKI we should be using, and we should be sending the patient to the expert for right choice so that the patient lives a long life. Thank you very much for giving us a clear message that this is a leukemia which is now curable, and that's a very good news. Sir, there is only one question in the chat box, if you permit.
I can see this. What is the guideline for monitoring PCR after you stop TKI? Guidelines are quite straightforward. You do monthly BCR-ABL by RQ-PCR from a reliable lab and preferably the same lab every month for 1 year, every 2 months for the second year, and every 3 months probably for the rest of the life of the patient. So guidelines are very clear. Majority of the relapses occur in the first 6 months. Few can occur up to 1 year, so such close monitoring. Because by this close monitoring, you'll be able to immediately restart your same TKI with which you had controlled and achieved DMR. So those are the guidelines, very straightforward.
Again, thank you very much, sir. There are no questions. I may request the panelists if they got to say something or ask some question to the sir. This is an opportunity. We've got some 2 minutes left with us. Sir wants to go at 8:20.
I just wanted to, sir.
Yes, yes.
Just wanted to know if you are putting patient upfront on second generation, after how many years you are giving a trial of TFR?
So second generation TKI, when you use them upfront, you should achieve the DMR which should last for minimum of 2 years, and the total duration of treatment should be minimum 3 years. Having said that, when I say that about 50 to 60% of patients remain in sustained remission, invariably these have been the patients who have taken the drug for the longest period and those who have remained in the DMR for the longest period. So if my patient has taken, say, imatinib for 18 years, so those who started in 2002, if I see them today, they have taken it for 18 years. And I look at their graph, the BCR level has been not detectable for last 15 years. And if they ask me, can I go for TFR? I will not tell them 40%. I will tell them that you got a chance of almost 90%. Because this is the longest treatment you have taken and you are in the DMR for the longest period. So now there are various methods of knowing who goes into the real TFR and who does not go, and how to increase this percentage of TFR. One of them is longest duration and the deepest of the response. But
Just
minimum
duration
3 years duration with 2 years of DMR on second generation.
Yes.
Can I have one question, sir?
Yes, Dr. Ritesh.
Sir, suppose this kind of patient who is on this therapy lands up in ICU, what would be the first thing that I should be considered as far as kind of common side effect or drug-drug interaction is concerned?
So, I suppose you're talking about landing up in ICU due to some other reason, right?
Other disease, yes.
Not due to CML, not due to the drug.
No.
So if the patient can take these are all oral drugs. If the patient can take the drugs by mouth and it can be absorbed, we don't stop these drugs because they are not really immunosuppressive. They don't do anything. Even in the COVID era, the recommendation is not to stop these TKIs. When you suddenly stop TKIs, you can invite trouble, and there can be a TKI withdrawal syndrome also that I talked about, and the BCR level can go out of control. Was that the only part of your question?
Any drug-drug interaction, sir?
So there aren't any significant drug-drug interaction with majority of these. You have to be careful with some side effect profile of the drugs. For example, dasatinib is bad for the lung and can cause pulmonary hypertension. Nilotinib is not so good for the blood vessels. Ponatinib is very bad for the blood vessels. So if somebody is admitted for, say, acute myocardial infarction, and if he is on ponatinib or nilotinib, he will have to go off these drugs permanently.
Okay.
Somebody is on dasatinib and gets admitted for, say, cardiac failure, right-sided cardiac failure due to pulmonary hypertension. He'll have to go off dasatinib lifelong. I apply this to renal failure also. Somebody is diabetic, hypertensive, gets into the renal failure. I put them off imatinib and bosutinib, and so on. So, side effect profile of the drug will tell you whether the drug has to go away.
Okay. Thanks.
Can I ask one question?
Sir,
Yes, Shashi.
Sir, now it's true that we have young CMLs, so that poses another problem. How you manage counseling regarding pregnancy to a female who is a reproducible age and wants a pregnancy?
Right. So,
how you do that?
Right. So there are lots of patients in India who are unmarried or just married and have not yet finished their family. So what we do is we tell them that if you are reasonably young, then just have patience, wait. Let me put you into complete remission, DMR, and let the DMR last for 2 years, so that your chance of relapse during pregnancy, when you're in pregnancy, you have to be off TKI. So when you're going to be off TKI for 9 months, your chance of relapsing is negligible. So person is very young, unmarried, just married, they are in 20s and early 30s, then this is possible. Now I have a patient who is 35, doesn't have a child, wants to have a child, has to be delivered, she has to become pregnant quickly. The obstetrician says she's 35, we are running out of time. Now this kind of patient, then you can probably take them off TKI and keep them on PEG interferon during the pregnancy. It is safe during pregnancy. Or there is even recommendation that just don't keep them on anything. The counts may slightly go up or not go up, or BCR may relapse, nothing much may happen. The moment they deliver, you can restart the treatment. Or, as was mentioned by Dr. Rosti, there are some patients, they say, I will not stop my TKI. I will not undergo termination, come what may happen. And 70-80% of babies are born normal. But that decision, of course, has to come from the family and the patient, not from you. So standard recommendation, stop TKI during pregnancy. Let the patient have DMR for 2 years so that the chance of relapse is very little. If this is a late age with pregnancy, then PEG interferon. And the patient desires to continue, don't interfere. Let her continue. Excellent chance that she will deliver a healthy baby.
Thank you, sir.
Sir, just last question is there.
Yes.
I think the gentleman wants to know about the first case.
Yeah, Manoj Kahar. Would you treat the case you described with total WBC count of 11,900 with platelet count of... Excellent question. I wish I had mentioned myself. CML is a fatal disease. Untreated CML, nobody can remain alive. So once you're diagnosed CML, BCR-ABL positive, however early it may be, the earlier the better. Next day, patient has to be, this is a real case. The one which I've described is a real case. Next day, the patient has to go on treatment. Absolutely. It's like, lymphoma, DLBCL. Patient has to be treated. Follicular lymphoma, wait and watch. Hardly I bother about it. It's non-curable disease. CLL, wait and watch, non-curable disease. Myeloma, you can wait and watch, early cases, non-curable diseases. But CML, acute lymphoblastic leukemia, Hodgkin lymphoma, DLBCL, these are curable diseases. So you don't waste a day. You take care of everything that is coming in the way of treatment and get on with the treatment. COVID era, no money, patient's education status, whatever it may be, just get on with the treatment. One more question has come in. Can we stop only during first trimester? No. The question is whether I can stop these drugs only in the first trimester and give them in the second half of the pregnancy. So theoretically you are sound, but that's not the recommendation. So I will do it only for those women who want to start. I will not recommend. I will wait and watch. Let her deliver, then ask her not to do breastfeeding and put her back on the treatment.
Okay, sir, on behalf of the organizers and all the participants, I would like to really extend heartfelt thanks to you. It has been a wonderful session. We thoroughly enjoyed, sir. So nice of you.
Thank you
Good
so
night,
much.
sir.
Thanks to
Thank you, sir. Thank you so much.
Thank you, sir.
Thank you, sir.
Bye-bye.
Thank you.
So now we move on to